Uh, uh, Good morning.
Good morning, sir. Good morning, sir.
Good morning.
Good morning, sir.
Good morning. So, okay. Uh, so we talked, we covered these innominate bones, right? We talked about the innominate bones, and then we talked about these ligaments, which were collectively making these two foramen, right? The sacrospinous and the sacrotuberous ligaments. And apart from that, we talked about the obturator foramen as well. Now, today we are supposed to cover the femur, the tibia, and the fibula. Along with that, see whether we are able to cover patella as well. We will try to cover that also. Uh, so let's start with the femur. Okay, we know that femur जो है that is one of the not one of the most, that is the longest and the strongest bone in the body, right? जो femur है, that is the largest bone, the longest bone in the body. And humerus में हमने पढ़ा था that was the longest bone in the upper limb, है यही था. Humerus was the longest bone in the upper limb, but the femur is the longest bone in the body. Okay, this much we know. And again, it is a long bone, and we can say that. Can anyone tell me which type of ossification we will find in femur? Whether it will be the
Notification.
it will be enchondral ossification, because it is a long bone. It will be enchondral ossification, not the intramembranous ossification. Now we saw the intramembranous ossification in the skull bones, na? And apart from that in the clavicle. Okay, so let's start with the anatomy of the femur. First of all, we will talk about this in orthopedics in detail. Like we are going to we'll be talking about the epiphysis, the metaphysis, and the diaphysis of a bone. Like what are these parts of a long bone, and what are their functions. But superficially here we can see that epiphyseal region is the part which articulates with another bone. Let's say if we talk about the femur, so here we can see that the proximal and the distal part of the femur which articulates with another bone. Let's say here we can see it is articulating with the acetabulum, and here we can see it is articulating with the tibia. So that part of the bone we call it as the epiphysis, and that's why we have got a cartilaginous plate in the children here, that is called as cartilaginous this plate that we can find here, na, which helps to increase the length of the bone, and eventually it gets converted into just a fused epiphyseal line when the ossification of the bone is completed. Okay, ठीक है. So apart from that, we can see this region between the diaphysis and the epiphysis. We have got the metaphyseal region. I think I talked about this thing that we have got a dense amount of blood vessels, specifically the veins and all those things which are closely present near the metaphysis, and because of that, the metaphyseal region has a high potential for any pathogenic any infection or any pathological condition. ठीक है, that is the metaphyseal region. And apart from the diaphysis में okay, that is the shaft region, and here we can see we have got two types of two things that we can talk about in the diaphysis. We have got the can anyone tell me what is a bone marrow? किसी को पता है? Can anyone tell me कि bone marrow होता है? हाँ निशा, क्या बोल रहे हो?
Bone,
हाँ, क्या बोल रहे हो? मैं समझा नहीं.
bone marrow is present in long bones, sir. It is a cavity.
It is the cavity. It is the hollow of the bone, or you can say the inner part of the bone that we talk about. That is the bone marrow. So in the shaft, we have got a yellow bone marrow and a red bone marrow. Precisely speaking, we have got a yellow bone marrow and a red bone marrow. Yellow bone marrow is specifically. We won't go into the detail of this thing, but we can say that yellow bone marrow is the. We can see that we have got these adipose tissues, that which are stored in the bone marrow, and that makes the yellow bone marrow. And apart from that, we can see we have got the red bone marrow as well, because we can see that this is the region where there is this formation of the RBCs. That is, yeah, it is a site for the origin of the RBC. Can anyone tell me the site or the part in the body where the RBC ends up after its life cycle? कहाँ पे? हाँ, it is the
Liver.
it is a spleen, na? Spleen. It is a spleen. Spleen is called as the graveyard of RBC, right? Where and does anyone remember how much days is the life cycle of an RBC?
120 days.
It is for 120.
120 days.
It is for 120 days. ठीक है, तो after the formation of RBC. Do you remember that process? You would have studied about it. Erythropoiesis, no? There are various different. I don't remember it right now, but there are various different stages through which the RBC goes, and we can see that there are it is nucleated in the starting stages, but when then we see that it is not nucleated in when the adult RBC is formed, and it is biconcave in shape, it is biconcave, and its diameter is something kitna hota है? It is I think 7 micrometer, something like that. 7 micrometer or something is its diameter. Just find it on the Google or somewhere. ठीक है, एक बार ये चीज़ चेक कर लो. ठीक है. Okay, so we have got a red bone marrow and a yellow bone marrow. Okay, but we can see that of course, since it is a long bone right now, if we are concerned with the anatomy part of this bone, though we are supposed to talk about the proximal part, the shaft, and the distal part. No? Okay, so first starting with the proximal part, we have to talk about the head of the femur and the neck of the femur. Along with that, we will talk about the greater and the lesser trochanter as well. Okay, then we will come to the shaft part, and then we will be talking about the distal part of the femur. Okay, let's talk about the proximal part. Of course, we have got the head. On the head of the femur, first of all, we have got this cartilage that is called as hyaline cartilage. Whenever we are supposed to talk about the part of the bone which is in contact with another bone, which is articulating with another bone, in that case, of course, we have got a cartilage which is present between both the bones, so as to prevent the rubbing of these two bones. Na? So we have got a cartilage that is called as hyaline cartilage. Hyaline, the term hyaline means glass-like, or you can say it is shiny type structure, or you can say shiny type of this cartilage, which is present on the articulating surface of the bones which connect to each other. So we can find this type of cartilage that is called as hyaline cartilage. Okay, and apart from that, we have got this one ligament on the head of femur that is called as ligamentum teres. Okay, so this ligamentum teres, this has two attachments. One attachment on the head of the femur, and another one inside the acetabulum. Okay, it connects the head of femur within the acetabulum, and attachments on the head of the femur and the acetabulum. Apart from that, if we are talking about the head of femur, we have got this region, this you can see this small depression like structure, small dip, that is called as the fovea capitis. Okay, the fovea capitis is the region. Fovea means a small, you can say, depression, and capitis means the head of femur. Okay, so we have on the head of femur we have got a region that is a small dip-like structure that is called as a fovea capitis. We won't find any hyaline cartilage in this particular region. We can see we have got the hyaline cartilage on all the overall head of femur, but we won't find any hyaline cartilage in this particular region, that is the fovea capitis, and this is the site of attachment for the ligamentum teres on the head of femur. Okay? Apart from that, it has another attachment on the inside the acetabulum, that is the ligamentum teres. Okay, I hope till now we are clear. We have just talked
Yes, sir.
about the ligamentum teres
Yes,
only.
sir.
Okay, now let's talk about the neck. First of all, talking about the neck of femur, here we can see we have got two borders and two surfaces. Of course, talking about the borders, the upper border and the lower border. Upper border, we can see it is more, not exactly, but more or less it is horizontal. Horizontal means this, like vertical means this. So we can see that the upper border means we're talking about the uppermost, extrememost part of the neck. So here we have got, this is the head of the femur, but we can see from this region up to somewhat this region we have got the neck of femur. So we can say that the uppermost part of the neck of femur is more or less horizontal, but the lowermost part, you can see it is more or less, it is oblique in shape. Or you can say the connecting line. If you try to connect both the greater and the lesser trochanter, you will find a line that will be the lower part of the neck of femur, then that is oblique. The upper part is more horizontal and the lower part is more oblique. Okay, now the thing that is important here is that if we talk about the surfaces, we have got two surfaces: the anterior surface that we can see right here, and the posterior surface on the opposite side, the anterior surface and the posterior surface. Now there are two structures that we need to talk about here. First of all, on the anterior surface, there is this line that we can see that connects the greater and the lesser trochanter, that is called as of course, simply the intertrochanteric line. The line connecting the greater and the lesser trochanter, that is called as intertrochanteric line. But if we have a look at the same structure from the posterior aspect, in that case we can see that it is not simply a line, but it is a dip like structure. It is a crest. सब ये चीज़ आई थिंक नोटिस कर पा रहे हैं ना. It is a crest. Like if you place your finger, you can place your finger inside this dip. Okay, that's why we are calling it as a crest. So on the posterior, this is the posterior view of this structure, and we can say that posteriorly we have got the intertrochanteric crest, but anteriorly we have got simply a line that is called as the intertrochanteric line. I hope we are clear with this thing.
Yes, sir.
Okay, never use the term intertrochanteric line when we are talking about the posterior aspect or vice versa. Okay, so we see the intertrochanteric line on the anterior side and the crest on the posterior side. Why the crest? Because it is a dip on the posterior side. It is a dip like structure. Okay, that's why we are calling it as a crest, not simply a line. Okay, intertrochanteric crest on the posterior side, intertrochanteric line on the anterior side. Two surfaces of the neck of femur, the anterior and the posterior surface, and we've got two borders. The upper border is more or less horizontal, and a lower border is more oblique than the upper border of the neck of femur. Okay, we are going to talk about the fractures of the neck of femur. I think we have discussed a bit of this. We talked about the different classifications for the fracture of neck of femur. हमने बात करी थी इसकी.
Subcapital and cervical वगैरह.
हाँ, transcervical and subcapital basal, that was है ना, that was on the basis of its anatomy, है ना. Apart from that, the Powell's and the Gardner's classification, I think we discussed that not in detail but at least superficially. Okay, so okay, we have talked about the intertrochanteric line and the intertrochanteric crest. So here we can see, we can appreciate the intertrochanteric. This is the anterior aspect, because now if let's say if you've got an image or a picture of a femur, you can easily figure out without looking at any other thing. You can just easily figure out whether that is the anterior part of the femur or the posterior part of the femur, just by having a look at this structure now, at the lowermost border of the neck of femur, whether you can see the intertrochanteric line or the intertrochanteric crest, and then you can easily figure out whether that is the anterior part of the neck of the femur that you are looking at, or the posterior aspect. uh, okay, so we have talked about the greater trochanter, the lesser trochanter. Okay, this is the greater trochanter. We will mm, mm, mm. Let's not talk about the muscle attachments right now. We are just looking at the structure of the bone. So we can see this is the greater trochanter on the lateral most side, the lesser trochanter on the medial most side. Unlike the humerus, in the humerus we saw that the greater tubercle was on the lateral side, or the lesser tubercle was on the anterior side. But here we can see both these trochanters are on the opposite to each other. Okay, this is the greater trochanter, this is the lesser trochanter. Okay, okay, and the intertrochanteric line anteriorly and the intertrochanteric crest posteriorly. We talked about the neck, we talked about the neck, we talked about the head, we talked about the neck of femur, we talked about the greater and the lesser trochanter, the intertrochanteric crest and the intertrochanteric line. Now we can see there are these some lines also. We can appreciate it on the posterior part of the shaft of femur. Okay, we are going to talk about these lines when we will be talking about the shaft. But before that, let's talk about its clinical relevance. Okay, so we can see that the most commonly we see that there is a fracture of the neck of the femur, that we can talk about if you talk about the clinical relevance of the neck of femur. Okay, here it is written that the fracture of neck of femur is more prevalent in women as compared to men. Can anyone give me any reason? कोई रीजन दे सकता है क्या?
ड्यू टू वाइडर पेल्विस के वजह से
ओके, हाँ, ओके ओके, हाँ ठीक है, कॉक्सा वेरा होगा, ठीक है. राम्या, कुछ बोल रहे थे?
because bone density and osteoporosis is
हाँ,
more prevalent in women, sir.
ओके, ठीक है. तो थिंग इज कि okay, of course the bone density is going to decrease after the menopause, but that we can talk about only after a specific in a specific time frame. But I think more relevant answer here is it has to do with the coxa vera. We know that in women there is a wider pelvis as compared to men, and because of that the neck of femur is more in coxa vera. Can anyone tell me whether the angle of inclination will it increase or will it decrease in case of coxa vera?
Decrease.
It will decrease, right? um, we can see it like this, na, कि Okay, so right now we are talking about the pelvis of a male. So in that case, we will see okay, it is this much wide, and we can see there are two acetabulum. There are two acetabulum, and we can see that the neck of femur is something like this. But now we can see the in case of women, the pelvis has become more wider. Since the pelvis is more wider, it means both the acetabulum are more apart from each other. So in that case, we will see, since the acetabulum is moving now more far away from the midline. In that case, you can see that the changes which is happening at the neck of femur. Since the acetabulum is moving more away from the midline, you will see this type of change will occur in the neck of femur, where the angle of inclination will decrease. The angle of inclination means the line between the head neck and the shaft. This angle will decrease, and or you can say there will be more amount of which force is medial to lateral or the lateral to medial. Which forces will increase on the neck of femur?
Medial to lateral.
Medial to lateral force will increase, and because of that we can say that okay, it will go into more coxa vara. Now because of coxa vara, we will see that there is more amount of bending force. Now there is more bending force. Let's say जब coxa vara में गया, so there is more bending force. If you try to bend a structure, of course it has more tendency to break, and that's why in case of coxa vara it will break easily. Unlike coxa velga is opposite to that, where there is lateral to medial force. So here we can see the head, the neck, and the shaft, they are almost in the straight in a straight line. Na? If we're talking about the coxa velga, तो उस केस में there is a very less chance of any fracture of the neck of femur, because all the forces are now in a straight line. But in case of coxa vara, we can see there is more amount of bending force. If I try to bend it more, it will break for sure. ठीक है? So that's why we can say that fracture of the neck of femur is more prevalent in women. Of course, there can be this reason also, जो राम्या ने बताया कि that there will be post-menopausal this decrease in the bone density, but that will be in a certain time frame. But overall, also we can say that there is more chance of fracture of neck of femur in women as compared to men, mainly because of the less angle of inclination or more amount of coxa vara. Okay. Apart from that, we can see in young patients they tend to occur as a result of high energy accidents. Of course, because we know that in case of young population, the bone density is much higher than the old people. So we can easily say that if we talk about the mechanism of injury, or we can say how the injury occurred in case of young individuals. Most commonly, it has to do with the high energy trauma, where let's say the person was running, or there was any road traffic accident. Because of that, there was a high amount of force that was put on the bone, and because of that the bone went into fracture. So we have to talk about high energy trauma or energy accidents for the fracture, most commonly in young individuals. But in the old individuals, most commonly we see, since the old individuals, they are not much indulged in sports activities and all those things, where there is a tendency of high force on the bone. So in old individuals, we see it can be because of low energy trauma. And now let's say the person was standing, and the foot slipped, and because of that the person fell down, or something like that. So we can see the low energy trauma can easily lead to any kind of fracture in case of old individuals, most commonly. And in case of young individuals, we will see it is most commonly because of high energy trauma. Okay. Now let's talk about the shaft of femur. I hope we are clear till now with the proximal part of femur. We talked about the
Yes,
head, है ना? ठीक है?
yes,
The
sir.
head, neck, the greater and the lesser trochanter, and the intertrochanteric. Is this the intertrochanteric crest or the line?
It's a crest.
It is the crest. यहाँ पे थोड़ा सा इस तरह से दिखाया गया होगा, तो it is the crest. ठीक है? So it means right now we are having a look at which part of the at the posterior. Yeah, yeah, exactly. We are having a look at the posterior aspect of the femur. Okay. So now, since we are supposed to talk about the shaft of femur, uh, you remember we talked about the shaft of humerus, and there we saw that the proximal part of the humerus is more or less oval shape. The mid part is more or less pentagonal in shape, and the lower part is more or less triangular in shape. I hope everyone remembers that.
Yes, sir.
Okay.
Yes, sir.
Okay. So here, if we talk about the shaft of femur, we can see. the proximal part of the shaft, it has got four borders and four surfaces. We are going to see how it has got four borders and four surfaces, but we will see that we have got four borders and four surfaces on the proximal part, this part of the shaft of femur. In the mid part of the shaft of femur, we have got only three borders and three surfaces, but in the distal part again we can see we have got three borders and three surfaces. So here we can see, first of all, if we talk about the borders in the proximal part, we can see that we have got this border, that is the medial border. Of course, this is the medial side, this is the lateral side of the femur. So this is the medial border. Then we have got this another line, another border, and this lateral border also. Okay. So if we talk about this border, that is called as the medial border. This one, that is called as the pectineal line. Okay, this is called as the pectineal line, and of course, there is a muscle attachment on this line. Can anyone tell me? The name goes like the name.
Pectineus.
Yeah, it is the pectineus. No? It is the pectineus muscle. The pectineus muscle is supposed to be attached on the pectineal line. Right now we are talking about the posterior aspect of the shaft of femur, and we can see we have got the pectineus muscle attached on the pectineal line, and it makes another border. The third border we can talk about on the proximal part of the shaft of femur posteriorly, that is the gluteal tuberosity. Okay, that is the gluteal tuberosity, and we can see the attachment of a muscle. Can anyone tell me one muscle that is attached on the gluteal tuberosity? That is
Gluteal max.
gluteus maximus. Okay, so because simply gluteus medius and gluteus minimus were attached on. Can anyone tell me on which surface of ilium?
Greater trochanter.
On the greater
नहीं नहीं
trochanter,
ilium.
हाँ, of ilium. ilium का
Gluteal surface.
gluteal surface, हाँ, नहीं, on the gluteal surface ना, we talked about three surfaces of ilium. The laterally it was the gluteal surface, medially it was कौन सा, iliac surface, or we were calling it as the iliac fossa, and the third one was the sacropelvic surface, where we saw the auricular surface where the sacrum was attached. I hope everyone remembers. हमने कल ही बात करी ना इसकी,
Yes.
ठीक है? Okay. So so simply we have got the gluteus medius and minimus attached on the pelvic surface, on the gluteal surface. So simply that those muscles don't have to do anything with the gluteal tuberosity. So here we can see we have got the gluteal tuberosity where the gluteus maximus is attached to gluteus maximus. So we have got the gluteal and apart from that we have got this another border that is called as the lateral border. So here we can see, if we talk about the upper one third of the shaft of femur, we can see we have got four borders: the lateral, the medial, pectineal line, and the lateral lip of the gluteal tuberosity. We have got the gluteal tuberosity, the lateral line, the pectineal line, and the medial border. Okay. So likewise, we can talk about four borders, and in the same way we can talk about four surfaces as well. This surface, this one, and on the anterior side we have got the anterior surface. So here we can see we have got an anterior surface, the posterior surface, then the lateral and the medial. So we have got the lateral surface, this one. Of course, it is supposed the lateral surface. Can anyone tell me the lateral surface will be between which two borders? This surface, ये वाला surface, it will be between
Linea aspera and
not the linea aspera. Linea aspera, we will this
lateral.
this line we are calling it as the gluteal tuberosity. Na? So we will say that between the gluteal tuberosity and the lateral border and the okay, we have got this surface that is called as the lateral, that we call as the lateral surface. Likewise, we have got this posterior surface, the medial surface, and on the anterior side we have got the anterior surface. I hope till now we are clear. We are going to talk about the linea aspera, but we will see we can see here that we have got four borders and four surfaces. Are we clear till now?
Yes, sir.
Okay, now let's come to the okay, let's talk about the medial, the middle part of the, or you can say the middle one third of the shaft of femur. Here we have to talk about the linea aspera. Linea aspera is simply a line on the posterior aspect of the femur, and we can see the continuation of these two lines is making the linea aspera. Okay, and in the middle one third we can see it is more or less triangular in shape. So we can talk about the posterior border, that is the linea aspera, the medial border, and the lateral border. And we can see, of course, we've got three surfaces: the medial surface, the lateral surface, and the anterior surface. I think it's like that only. Yeah, the lateral surface, the medial surface, and the anterior surface. Okay, we've got three surfaces and three borders in the middle one third of the femur. We had four borders and four surfaces in the upper one third of the femur, three borders and three surfaces in the middle one third of femur, and we have got a linea aspera. then when we come to the lower one third of the femur, again we have got four borders and four surfaces. This line, this is the medial supracondylar line. This is the lateral supracondylar line. This one, okay, this is the lateral supracondylar line. This is the medial, and then we have got the lateral border and the medial border. So we can see we have got the lateral, the medial, no, here the lateral border, the medial border, and then the lateral and the medial supracondylar lines. So likewise, we can talk about four borders, and then we have got four surfaces. So we can say that we have got four borders, four surfaces in the lower one third, three borders, three surfaces in the middle one third, and then again four borders and four surfaces in the upper one third of the femur. I hope we are clear till now.
Yes, sir.
Okay, just remember the names: the pectineal line and the gluteal tuberosity, and the sublateral and the medial supracondylar line. Okay, okay. And apart from that, here it is also written that of course the femur is not supposed to be in an erect position. Na? It is in an oblique position in the body. कहीं पे यहाँ पे दिखाया तो नहीं है. हाँ, here we can see. Even it is even more oblique than this thing that they have shown here. It is even more oblique than this. Okay, and it means that the distal, you can say the distal condyles are even more medial to the head of femur. Okay, and the reason for that is of course because we can it helps to bring both the knees more closer to the midline so as to improve the amount of you can say the stability of the person. Okay, for that reason we can see that of course we can see that the more you can say more closer both the legs are, more is the stability of the person. So because of that we can see both the femur, they are present in an obliquity, and the distal part, or you can say the distal condyles of both the femur are even more medial to the head of femur. Okay, so that's all with the shaft of femur. We have talked about the shaft, we have talked about the head, and we have talked about the neck, and then we have talked about the intertrochanteric line and the intertrochanteric crest. I hope we are clear till now.
Yes, sir. Yes, sir.
Okay, now with the shaft of femur, most commonly we will see the fracture of the shaft of femur. Okay, we are going to talk about these type of fractures in ortho, but we will see that okay, it depends upon, so they have classified it according to the fracture line. So we can talk about different types of fractures depending upon the line of fracture. This is the oblique type of fracture where we can see an oblique line. Likewise, this is a comminuted type of fracture where we can see at a particular segment there has been a fracture, and that part has broken down into various different fragments, into fragment. It is not that clear, but we can simply see that it has broken down into fragments. That is called as comminuted type of fracture. This is the spiral fracture because of, you can say, let's say if there is any axial torsion. Let's say the person was bearing weight on this leg. The distal part of femur was stable, and the person tried to rotate the torso. Torso को, trunk को person ने rotate करने का एकदम से, pelvis को person ने rotate करने का try किया suddenly, and because of that there was axial this force that will lead to this spiral type of fracture, and that is called as spiral fracture. This is the compound. This is not a compound fracture. Compound fracture is a different thing. Compound fracture, we can see that let's say in a single bone, if we have got two different type of fractures, let's say we have got a transverse fracture here and then an oblique fracture here, then we can call both the fractures collectively as the compound type of fracture. Okay, and they've shown this thing wrong, because if we actually talk about the type of the most commonly when if there is a shaft of femur fracture, in that case we will see the proximal fragment of the femur will move laterally, and the distal fragment of the femur will move more medially. So they have not shown it properly here, but most commonly we will see that if there is any fracture of the shaft of femur, in that case what we see that the proximal fragment of the fractured femur will move laterally, and the distal part of the fragmented femur will move medially. It has to do with the muscle attachment. Of course, we can see that we have got the abductors which are attached on the proximal fragment, and because of the contraction of the abductors, we can see the proximal fragment will move more laterally, and because of the attachment of the adductors, the distal fragment will move more medially. It means that if there are muscles which are attached to a bone, and if the bone has gone into fracture, it means the contraction of the muscle which are attached to that bone can have an effect on you can say disaligning the fragments of the bone ना उसको bone को fragments को disalign करने के लिए one of the major जो चीज़ काम कर सकती है that is the muscles which are attached to that bone है ना and इससे हम क्या देखते हैं कि even though we reduce the bone, can anyone tell me कि bone को reduce करना क्या होता है, मतलब fracture के बाद हम bone को reduce करते हैं, reduction करते हैं. Can anyone tell me कि what is the reduction?
Alignment.
Fracture reduction. हाँ,
Alignment.
we are realigning both the fractured fragments को वापस हम अपनी जगह पे लेके आते हैं. We can try it by various different methods. We can go for the conservative method. First of all, we try the conservative method where we let's say we are giving it something traction on our own or something like that, and we try to realign it. अगर नहीं काम करता, in that case we need to go for some kind of traction where there is a continuous traction on this thing, and इसको traction दिया जा रहा है, मतलब इसको खिंचाव दिया जा रहा है, and उसकी वजह से both the fragments they come back to their original position. And अगर वो नहीं किया जाता, in that case we need to go for internal this thing, open reduction and internal fixation. So we need to go for that in those cases. Again, there are various aspects when we can decide whether we need to go for internal reduction or not. Like let's say there was a fracture of a particular part of femur, and along with the fracture there was let's say there was some sepsis or some pathological condition which developed along with the fracture ना. Let's say कोई pus formation वहाँ पे हुआ, या फिर let's say कोई infectious disease वहाँ पे साथ में हो गई. So in that case we are not supposed to go for open reduction and internal fixation. In that case we will try to go for the external fixation only. We don't want to open it up and then close it back, because in that case we might affect it even more, we can damage it even more. So in that case we would prefer to go for external fixation. If there is a clean wound, let's say, and if there is a simple fracture, and let's say if there is no infection or something like that, in that case we can just open it and we can go for open reduction and the internal fixation. So we can decide ki in which cases we need to go for which type of operative method. We will talk about that in ortho, but here we can see ki the different fragments of the fractured bone, they can move in different directions because of the contraction of the muscles which are attached to these fragments of the bone. Okay, I hope till now we are clear.
Yes, sir.
Okay.
Yes, sir.
Okay, and now let's talk about the distal part. The distal part में here we can see that we have got a lateral condyle and a medial condyle. Okay, we have got a lateral condyle and a medial condyle as a whole. We can see here that the lateral condyle is more now the medial condyle is more, you can say, more convex, more prominent, more distal than the lateral condyle, and you can say more convex. So in that case, let's talk about their attachment with the tibia. अगर tibia के साथ में attach करते हैं, तो in that case, don't you think that there will be more amount of surface area which will be of the femur, which will be in contact with the tibia from the lateral epicondyle, है ना? Lateral epicondyle का जो surface होगा, since it is less convex, it is more flat, you can say, as compared to the medial condyle. So we can say that more amount of surface area of the lateral condyle will be in contact with the tibia as compared to the medial condyle. So कोई बात समझ आई?
Yes, sir.
Okay, ठीक है. So since this medial condyle is more convex, so it means only a small part of the medial condyle will be in contact with the tibia, but a more amount, you can say, from here to here, almost this much part of the lateral condyle will be in contact with the tibia. It means that since more surface area of the lateral condyle is in contact with the tibia, so if we talk about joint, let's say the amount of pressure, can anyone tell me कि ज़्यादा pressure कहाँ पे होगा या फिर ज़्यादा compression कहाँ पे होगा, on the lateral condyle or on the medial condyle? If we talk about compression, it is force upon area, है ना, मतलब amount of force that is being put on certain amount of area. Let's say if the area of contact decreases, अगर area decrease कर रहा है, तो in that case amount of you can say the compression, it will increase, है ना, दोनों surfaces के बीच में. I am talking about the tibia and the femur, दोनों के बीच में amount of compression will increase if there is less surface area and more amount of force that is being transmitted through the medial condyle. सबको समझ आ रहा है कि नहीं?
Yes, sir.
फोर्स इज, ठीक है, और यू कैन यूज द टर्म प्रेशर. प्रेशर इज फोर्स अपॉन एरिया ना. तो अगर एरिया डिनोमिनेटर अगर है तो एरिया अगर कम हो गया द होल वैल्यू विल इंक्रीज, है ना. डिनोमिनेटर अगर कम होगा तो होल वैल्यू जो है वो इट विल इंक्रीज. तो इन दैट केस वी कैन से दैट यहाँ पे एरिया जो है वो कम कॉन्टैक्ट में है. इसका प्रेशर वाला जो एग्जाम्पल है वो हम स्कूल में पढ़ते थे ना. जो हमारा बैकपैक होता है उसका जो स्ट्रैप होता है, इट इज़ सपोज टू बी वाइडर. जितना वाइड होगा उतना उतना एरिया ऑफ कॉन्टैक्ट ज़्यादा होगा एंड उतना प्रेशर कम होगा. यही होता है. आई होप यही पढ़ते थे हम, है ना.
Weight transmission.
या वेट फोर्स ट्रांसमिशन. जो हम लेट्स से दो दो बैकपैक है हमारे पास. एक बैकपैक, दोनों बैकपैक 5 kgs की है. एक बैकपैक का जो स्ट्रैप है वो जस्ट मतलब ज़्यादा वाइड नहीं है, बहुत थिन है. एंड दूसरा बैग जो है उसका स्ट्रैप बहुत ज़्यादा वाइड है. तो दोनों में से कौन सा आपके लिए ज़्यादा कंफर्टेबल होगा? जिसका
Wide वाला
हाँ वाइड वाला.
comfortable. Wide is strong.
या बिकॉज देर इज मोर सरफेस एरिया विच इज इन कॉन्टैक्ट एंड बिकॉज ऑफ दैट जो 5 kg वेट जो है इट इज़ बिंग डिसिपेटेड अलॉन्ग दैट वाइड स्ट्रैप ना. तो बिकॉज ऑफ दैट जो हमारा कंफर्टेबल होगा दैट दैट विल बी वो वाला जिसका जिसका स्ट्रैप जो होगा दैट विल बी मोर वाइड. तो सेम चीज़ हम यहाँ पे बोल सकते हैं ना कि सिंस the lateral condyle has more surface area in contact with the tibia, so we can see that less pressure will be on the lateral condyle but more will be on the medial condyle since it is more convex. Okay, but here we can see this कि that the medial condyle is more distal than the lateral condyle. But of course जब हमारा tibia है, tibial plateaus or the tibial condyles they are more or less flat. तो how come they are supposed to get attached with the tibia? कोई बताएगा? यहाँ पे टीबिया प्रेजेंट होगी, टीबिया प्रेजेंट है तो टीबिया के जो दोनों कॉन्डाइल्स है दे आर फ्लैट. बट फीमर में वी कैन सी द मीडियल कॉन्डाइल इज मोर, यू कैन से इट इज डिस्टल टू द लैटरल कॉन्डाइल ना. तो इट इज़ द ऑब्लिक्विटी ऑफ द फीमर, राइट. अगर फीमर जो है फीमर इज ऑब्लिक ना, फीमर इज यहाँ पे हम फीमर को देख रहे हैं तो दिस इज देन इरेक्ट फीमर, है ना. इरेक्टली वर्टिकली इरेक्ट जो फीमर है. लेकिन अभी अगर हम इस फीमर को ऑफकोर्स अगर हम बॉडी में देखते हैं तो बॉडी में वी सी कि दैट द फीमर इज प्रेजेंट एट एन ऑब्लिक्विटी, है ना, ऑब्लिकली प्रेजेंट है लाइक दिस. here we can see since the femur is present obliquely, now both the condyles they are both in the same along the same plane, है ना. and now they can easily articulate with the flat tibial condyles. I hope सबको समझ आया,
Yes, sir.
है ना.
Yes, sir.
तो अभी जब हम वर्टिकली इरेक्ट फीमर की जब अगर इसको अगर प्लेस करेंगे इन दैट केस वी विल सी दैट द मीडियल कॉन्डाइल विल बी मोर डिस्टल टू द लैटरल वन. बट सिंस इट इज ऑब्लिकली प्लेस्ड देन वी कैन सी इजीली that both the condyles they articulate easily with the flat tibial condyles. Okay, now there is one more thing. If we are supposed to talk about the concave and the convex rule in the knee joint, can anyone tell me कि which bone will be the concave one and कौन सी हमारी convex bone होगी?
So femur convex and tibia concave.
हाँ, femur will be convex and tibia will be concave. But tibia, as I mentioned, that tibia, the proximal part of tibia, it is more flat. It is flat ना, तो how come it is supposed to provide concavity?
Sir, because of presence of meniscus.
Yeah, exactly, and it is the presence of the meniscus. So it means in the knee joint, it is the meniscus which is providing the concavity, and then we can talk about the concave convex rule. The convexity being provided by the distal femoral condyles and the concavity being provided by the menisci, not the tibial condyles. Tibial condyles are flat. Here we will see this. यहाँ पे है ना. Here we can see tibial condyles are flat, they are not concave. So it means it is the meniscus which provides the concavity, and then again we are supposed to it means by the concavity of the meniscus now they fulfill the requirement for the concave convex rule, and now we can talk about that rule in the knee joint. Okay, so it means it is the meniscus which provides the concavity and not the bone. But simply in the books it is mentioned that that the tibia is concave and the femur is convex, but actually we must know that it is the meniscus which is concave, not the tibia precisely. ठीक है. Okay, I hope
Okay,
we are
sir.
clear. And ठीक है, lateral condyle it is less prominent and the medial more prominent and it is more convex also. And we can see on the anterior side we will talk about this thing. On the anterior side we can see we have got this bone, that is the patella na, but the patella is attached to the femur. patella has its attachment on with the femur. Not just remember this. It has not. It has don't have any attachment with the tibia. So we talk about the patellofemoral joint. We don't talk about the patellotibial joint. You know? We talk about the patellofemoral joint. So it means that the patella has its attachment on the anterior aspect of the distal part of the femur, and on the posterior part we have got this intercondylar fossa. We'll talk about the significance of the intercondylar fossa, how it improves the stability of the patella. We will talk about that. But we can see on the posterior side we have got this fossa, and also we can talk about this particular surface. We can call it as the popliteal surface, because of course there is this muscle. Can anyone tell me which muscle is present on the posterior aspect here? A small muscle, triangular shape. Popliteal muscle, na? Popliteal muscle is present here, and of course that muscle is supposed to. Can anyone tell me the function of the popliteus? कोई बताएगा? Popliteus muscle.
Locking of knee joint.
Okay, so there are two things, two mechanisms of the knee joint. There is locking, and then there is unlocking of the knee joint. So we can, it is for the locking or for the unlocking? It is for unlocking. Popliteus muscle is for the unlocking of the knee joint. Locking के लिए, it is the vastus medialis. Vastus medialis is responsible for the locking of the knee joint. Precisely, it is called as vastus medialis oblique, VMO. Vastus medialis. Can anyone tell me vastus medialis is part of which group of muscles? Vastus quadriceps group of muscles, na? So on the medial side we have got this muscle that is called as vastus medialis. Vastus medialis has got two different type of fibers. Proximal fibers जो होते हैं vastus medialis, they are I think something longus or something like that, and the distal fibers which are in contact with the knee joint, those have got oblique fibers, and then that's why we call it as vastus medialis oblique. So vastus medialis is responsible for knee locking, and for knee unlocking it is the popliteus muscle. We will see that how it is functioning as to provide knee joint unlocking. And okay, till now we are done with the distal part of the femur. Okay, let's talk about the concave and the convex rule of the knee joint. Can anyone tell me ki, let's say the person is in weight bearing position. So in that case, first of all, which will be the bone जो कि translate करेगी, जो movement show करेगी, and which one will be the stable bone? Okay, when the person is bearing weight, in that case you said that it will be the femur which will show the movement, and not the tibia. By saying movement, I mean the arthrokinematics, the translatory and the rolling movements, all those things. तो जो हमारा arthrokinematics हो रहा है between the articulating surfaces, that we can see happening in the femur and not with the tibia when the person is bearing weight. It means again simple है ना, तो कि जब person weight bear कर रहा है, in that case tibia is supposed to be stable and femur is supposed to be moving. The articulating surface of the femur is supposed to be moving. And opposite to that, let's say when the person is sitting on a quadriceps chair in a high sitting position, in that case now the person is trying to do knee joint extension and flexion. In that case, which bone will show the arthrokinematics?
Tibia.
It will be the tibia, na? Because now the tibia is free to move, and now the tibia will show the arthrokinematics. Okay, simple. Now the thing is that if we talk about which one, let's talk about the femur. No, let's talk about the tibia first of all. So let's say the person is in the sitting position, and now the person is free to move the legs, and now the person is doing knee joint extension. So in that case, first of all, can anyone tell me कि knee joint extension के time पे in which direction the tibia is supposed to translate? Is it supposed to translate anteriorly or posteriorly during knee joint extension?
Anteriorly.
Okay, you said anteriorly, और बाकी सब?
Posteriorly.
नहीं, okay, it was anteriorly. निशा change क्यों answer? It is anteriorly ना. देखो, the thing is concave convex rule की अगर हमें बात करनी होती है, simply we must know that first of all let's talk about इसको मैं इस तरह से दिखाता हूँ. Let's talk about whenever we are talking about two different bones जो articulate कर रहे हैं, अगर हम concave convex rule की हमें बात करनी है, we are supposed to talk about the arthrokinematics, है ना, or we can say the translatory and the rolling motion, or that we can see at the articulating surfaces of the bone. So let's say first of all, whenever we see the articulating surface, एक bone जो है that is supposed to be convex and another bone is supposed to be concave, है ना. अब movement जो होगी that will be like this ना. Let's say this is the knee joint. तो knee joint पे this is knee flexion, this is knee extension that is happening here. Okay. तो first of all concave convex rule बोलता क्या है कि अगर हमारा convex वाली bone जो है, let's take the convex bone first of all. So what we see that if the shaft of this convex bone, or you can say if the body of the convex bone, or the rest of the part of the convex bone, if it moves in one direction, the articulating surface of the convex bone will translate in the direction opposite to that. तो here we can see कि let's say ये हमारी टीबिया है. टीबिया का जो कॉन्केविटी है वो स्टेबल है. अब हम देख रहे हैं कि हमारी फीमर जो है दैट इज फ्री टू मूव. अब फीमर जब मूव कर रही है तो here we can see ना कि shaft of femur is if it is moving superiorly, then we can see the articulating surface ये किस डायरेक्शन में मूव कर रहा है. अगर shaft superiorly मूव कर रहा है तो articulating surface it is moving in which direction? Inferiorly ना. हाँ मतलब inferiorly. if it is moving superiorly upwards, तो this articulating surface is moving downwards है ना. यही होगा. right now the concave bone is stable and I'm talking about the convex bone right now है ना. तो convex bone में during this movement तो body is moving in one direction and the articulating surface is moving in opposite direction है ना. same यहाँ पे भी होगा. जब body is moving in the downward direction, in that case the articulating surface is moving in upward direction. ठीक है. I think this thing is clear to everyone. ये वाली चीज़
Yes, sir.
ठीक है. एंड इसी को अपोजिट कर दो जहाँ पे टीबिया मूव कर रही है और लेट्स से कनकेव बोन अगर मूव कर रही है तो वो कहाँ पे कर रही थी? नॉन वेट बेरिंग में ना. in the non-weight bearing we saw that the tibia was moving and the femur was stable. So in this particular case we will see now if we will see the concave bone will be moving and the convex bone will be stable. Here we can see now if the shaft or you can say the body of the concave bone is moving in one direction, just tell me कि उसका articulating surface किस direction में move कर रहा है? इस same direction में ना.
Same
है ना.
direction.
if the shaft is moving in this direction, the articulating surface is also translating in the same direction ना, upward direction. तो it means अब आप समझ जाओ किस तरह से इसको wording यूज करनी है कि if we talk about the convex bone, in that case if the rest of the bone is moving in one direction, the articulating surface of the bone of that bone translates in the direction that is opposite to that and completely opposite for the concave bone. ठीक है. Now let's talk about जो हमने अभी एग्जांपल लिया नी जॉइंट का. किसका हमने एग्जांपल लिया था? नॉन वेट बेरिंग में ना. नॉन वेट बेरिंग में when the person is on a chair, let's say the person is sitting on a quadriceps chair ना. quadriceps chair पे person बैठा हुआ है and the person is doing knee joint extension. तो in that case which bone is moving? Is it the concave bone or the convex bone? कौन सी bone move कर रही है? It is the concave bone ना. It is the concave bone. जब person is sitting on a chair and now the person is doing knee joint extension or flexion, in that case concave bone tibia is moving ना. femur is stable. तो in that case अगर tibia का shaft जो है while doing knee extension, the shaft of the tibia is moving anteriorly है ना. let's say ये हमारा femur है. right now we are sitting on a chair. ये femur है and ये हमारा tibia था. ठीक है. now right now the knee joint is in 90 degree of flexion. now we are doing knee joint extension है ना. of course the tibia is supposed to move because we are sitting in non-weight bearing position. तो इस position में while doing knee joint extension जहाँ पे shaft हमारा anteriorly move कर रहा है तो the articulating surface is also supposed to translate anteriorly है ना, in the same direction. and जब हमारा knee joint flexion हो रहा है the shaft is moving posteriorly and the articulating surface is also supposed to translate posteriorly. ये हमारा हो रहा है during non-weight bearing ना. सबको समझ आया? एंड इसी का अपोजिट अगर हम कर देते हैं कि पर्सन अगर वेट बेरिंग में आता है, लेट्स से अगर पर्सन स्क्वाटिंग कर रहा है तो स्क्वाट्स के टाइम पे जब पर्सन स्क्वाट डाउन कर रहा है उस टाइम पे नी जॉइंट पे क्या होता है? फ्लेक्शन की एक्सटेंशन व्हाइल स्क्वाटिंग डाउन. फ्लेक्शन हो रहा है नी जॉइंट पे फ्लेक्शन हो रहा है. इन दैट केस इज द which bone is moving? Is it the tibia or the femur?
Femur.
It is the femur है ना. तो we have to talk about the articulating surface of the femur. We have to talk about the translatory movement of the femur, not the tibia, because now the tibia is stable. and now while doing knee joint flexion, अब आप ये खुद से फिगर आउट करो कि shaft of femur अगर कहाँ मूव करेगा during knee flexion. shaft of femur कहाँ मूव करेगा? ये tibia है. tibia अभी स्टेबल है, पर्सन वेट बेयर कर रहा है एंड ये पर्सन अभी स्टैंडिंग पोजीशन में है. ये फीमर है. आई होप सब पिक्चराइज कर पा रहे हैं इस चीज़ को. ठीक है. ये टीबिया है, ये फीमर है. अब पर्सन स्क्वाट डाउन कर रहा है, इट मीन्स ऐसा वाला मूवमेंट हो रहा है जहाँ पे नी जॉइंट जो है वो ऑलमोस्ट 90 डिग्री में आ रहा है, एंड देन पर्सन वापस नॉर्मल पोजीशन में आ रहा है. तो इट मीन्स वाइल कमिंग डाउन जो शाफ्ट है इट इज मूविंग पोस्टीरियरली. तो इट मीन्स इट कि इस पर्टिकुलर टाइम पे जब पर्सन स्क्वाट डाउन कर रहा है उस टाइम पे जस्ट हैव अ लुक एट द आर्टिकुलेटिंग सरफेस ऑफ द टीबिया. ये किस डायरेक्शन में मूव कर रहा है?
Superiorly or
Anteriorly. This is the anterior part, na?
Anteriorly.
हाँ, right now the person is standing position में. This is the anterior part of the person, this is the posterior part of the person, ना? तो यहाँ पे person जब squat down कर रहा है तो in that case it is moving anteriorly, ना? So it means now the shaft or the articulating surface of the femur is translating anteriorly when the person is squatting down during weight bearing position. ठीक है? ओके, तो सिंपली अगर आपसे कोई पूछता है कि नी जॉइंट पे, लेट्स से नी जॉइंट फ्लेक्शन या नी जॉइंट एक्सटेंशन पे कौन सी बोन का ट्रांसलेशन कहाँ हो रहा है, फर्स्ट ऑफ ऑल योर क्वेश्चन शुड बी कि वेदर द पर्सन इज इन वेट बेरिंग और इन नॉन वेट बेरिंग. देन वी कैन डिसाइड दैट विच इज द बोन विच इज सपोज टू मूव, एंड देन वी कैन फिगर आउट कि फर्स्ट ऑफ ऑल वी हैव टू टॉक अबाउट द मूविंग बोन, एंड देन वी कैन फिगर आउट कि नी जॉइंट जो भी है फ्लेक्शन हो रहा है या एक्सटेंशन हो रहा है, अकॉर्डिंगली वी कैन फिगर आउट whether the concave bone is moving or the convex bone is moving, and then we can easily come up with the answer whether there is supposed to be an anterior translation or a posterior translation. ठीक है? I hope everyone got the point. सेम लाइकवाइज हम अगर अगर है ना, अगर एबडक्शन की बात करते हैं लेट्स से ऑफ द शोल्डर जॉइंट, तो शोल्डर पे क्या हो रहा है, ये हमारा ग्लिनॉइड फोसा है, दिस इज द हेड ऑफ फ्यूमरस. राइट नाउ वी आर डूइंग आर्म एबडक्शन. तो आर्म एबडक्शन के टाइम पे शाफ्ट इज मूविंग सुपीरियरली एंड द आर्टिकुलेटिंग सरफेस ऑफ द हेड ऑफ फीमर इज मूविंग इन विच डायरेक्शन?
inferiorly?
इन्फीरियरली, है ना, कॉर्डली. ठीक है, डाउनवर्ड इट इज मूविंग. ठीक है, तो डाउनवर्ड मूवमेंट जो है, कॉर्डल मूवमेंट जो है वो हमारा हो गया. ठीक है, आई होप वी आर डन विद द कॉनकेव कॉन्वेक्स रूल.
तो सर
हाँ,
शोल्डर पे कॉन्वेक्स कॉनकेव रूल लगेगा या कॉनकेव कॉन्वेक्स रूल लगेगा?
शोल्डर पे कॉनकेव कॉन्वेक्स रूल लगेगा ना, मतलब हमारा कॉनकेव ग्लिनॉइड फोसा है एंड हेड ऑफ ह्यूमरस जो है वो कॉन्वेक्स है. ठीक है, ओके.
यस सर.
तो इट विल ट्रांसलेट इन्फीरियरली, ठीक है, ड्यूरिंग आर्म एबडक्शन. ओके, now let's talk about the tibia. We are done with the femur and let's talk about the tibia now. Okay, we can see that it is a shin bone. We call it as a shin bone. We can see this region. So, and again we have got three borders here. We can see this anterior border. It is very sharp and it is easily palpable. है ना? We can easily palpate this anterior most part of the tibia. And I think this is one of the most, you can say, most common part of this bone, or the bone which is easily जहाँ पे we see there is a lot of not the injury but काफ़ी blow होता है यहाँ पे, specifically in the people who are playing. let's say अगर आपने फुटबॉल काफ़ी खेला है या इवन क्रिकेट भी अगर आपने काफ़ी खेला होगा, you must know कि this is the part of the bone जहाँ पे बहुत ज़्यादा मतलब इंजरी होती है. बिकॉज इंजरी इन द सेंस कि मतलब फुटबॉल अगर खेल रहे हो तो दिस इज़ द पार्ट जो कि बहुत काफ़ी प्रोन है to blow, है ना, and easily you can see this part of the bone getting affected quite commonly. So that is called as the shin bone. And okay, we will talk about all these structure, all these features in a bit, but here we can see again we are supposed to talk about the proximal, the shaft and the distal parts. Proximal part maybe we will see. Okay, here we can see ki this part of the tibia is making the medial malleolus. Lateral malleolus is being made by the fibula, and there was a question that I asked yesterday. किसी ने देखा why we use that thing? Okay, we will talk about that. Let's say अगर time allow करते तो we will talk about that. क्या question क्या था हमारा? leg length पे था ना, leg length discrepancy पे.
Sir, why from umbilicus?
हाँ, why from umbilicus and to the medial malleolus we use it for measuring the this thing, the apparent limb length discrepancy, and why not for the true limb length discrepancy? Okay, we will talk about that. But now यहाँ पे we will see that we are seeing that this is making the medial malleolus, and since tibia makes the medial malleolus, that is the reason why we measure the leg length discrepancy from, let's say, the ASIS or the umbilicus up to the medial malleolus, na? Because tibia is the main weight bearing bone here. Okay, so let's talk about the proximal part of the tibia. We can see, first of all, we've got two condyles, the medial condyle and the lateral condyle. This is the medial one sorry, this is the medial one, this is the lateral one. On the lateral condyle we can we are supposed to talk about this particular tubercle. I think इसका किसी ने नाम लिया था 2-3 क्लास पहले. That is the Gerdy's tubercle, but I think किसी और मसल के aspect में आपने आपने नाम लिया था, but it is actually the site of attachment for the IT band or the IT tract, ठीक है, iliotibial tract. So we see that from the aponeurosis of the TFL and you can say the gluteus maximus also we have got this aponeurosis. From that aponeurosis we have got this continuation, this band or this tract that is called as the iliotibial tract, and eventually it has got its insertion or its attachment on this particular tubercle that is called as the Gerdy's tubercle. Gerdy's tubercle is present here. This is the lateral part of the tibia, this is the medial part of the tibia. So we can say that on the proximal and the lateral part of the tibia we have got this particular tubercle that is called as the Gerdy's tubercle, and we have got the attachment of the IT tract on this particular part of the tibia. Okay, apart from that we have got the lateral and the medial condyles, and then we have got the the tibial tuberosity. Tibial tuberosity is basically this particular part. Here we can see a small prominent region on the proximal part of tibia that is called as the tibial tuberosity. Can anyone tell me कि यहाँ पे क्या attach होता होगा?
Quad muscle.
We have got the patellar tendon, है ना? Of course the quadricep muscles have the quadricep, you can say the tendon present up to the this thing, up to the patella. Over the patella it moves and then it gets attached on this particular part of the tibia that is called as the tibial tuberosity, है ना? Tibial tuberosity पे हमारा attachment होता है. Okay, चलो इस पे हम अभी आते हैं. पटेला जो है, पटेला increases the movement arm for the quadriceps so as to while it is producing the torque ना. जो पटेला होता है, पटेला, it increases the movement arm for the torque for knee joint extension ना. चलो इसके बारे में हम बात करते हैं थोड़ी देर में, बट हम देखते हैं कि पटेला की वजह से it becomes easier for the quadricep muscle to provide knee joint extension. अगर पटेला प्रेजेंट नहीं होती, इन डैट केस क्वाड्रिसेप को ज़्यादा फोर्स प्रोड्यूस करना पड़ता है नी जॉइंट एक्सटेंशन टॉर्क प्रोड्यूस करने के लिए. उसके बारे में अभी हम बात करते हैं थोड़ी देर में, लेकिन अभी हम यहाँ पे देख रहे हैं दैट वी हैव गॉट द tibial tuberosity and it is the site for the attachment of the patellar tendon na? Here. Okay, so we have got a patellar tibial tuberosity. We are on the lateral side here we have got the Gerdy's tubercle, and ठीक है, that is the site for the TFL attachment, and then the lateral and the medial condyle, and we have got the intercondylar fossa as well. The intercondylar, between both the condyles we have got the fossa region that is called as the intercondylar fossa. ठीक है, here we have got the intercondylar fossa. We can see again the medial condyle is much bigger than the lateral condyle. ठीक है, and then we have got the intercondylar eminence, and we have got the medial intercondylar tubercle. We call it as spikes as well. इसको हम spikes या spines भी हम बोलते हैं. ठीक है, lateral spine and medial spine, या फिर simply we can say that these are the two intercondylar tubercles. ठीक है, and then we have got an eminence in between, that is the intercondylar fossa or the eminence. ठीक है, okay, and then the medial condyle and the lateral condyle. Medial condyle is much bigger than the lateral one. Okay, ठीक है, that was that we have talked about the proximal part. Now let's talk about the shaft. I hope ये boring नहीं हो रहा कि ठीक है? Is it good?
Yes, sir.
ठीक है.
ठीक है, चलो ठीक है. Okay, तो now we are talking about the shaft of the tibia. एक बार shaft की बात कर लेंगे, उसके बाद इसका functioning पे आएंगे. वो चीज़ बड़ी interesting है. तो shaft में we can see first of all we can say that it is prism shaped bone or prismoid, not the prism but prismoid. So there is a difference between prism and prismoid ना. Prism simply हम जो prism वो triangular जो होता है ना, 3-dimensional triangle, उसको हम prism बोलते हैं. Long उसी को अगर आप ऐसे अगर देखोगे, long prism, that is called as prismoid. तो you can say it is prismoid. They can use this term in the exam or something, तो इसलिए it is important to just know the term that is prismoid in shape. And we have got, of course, we have got 3 borders and 3 surfaces. Simply the anterior border is, you can say it is more or less S shaped in structure, starts all the way from the lateral condyle, or you can say from the tibial tuberosity, and all the way it goes up to the medial malleolus. Okay, and that is the anterior border, and it is S shaped. Okay, then we can talk about the medial border and then the lateral. So this is the medial border, and then we have got the lateral border. Of course, the lateral border is supposed to be the introitious border here, na? जो lateral border होगा that will be the introtious border. Why? Because we have got the fibula that is present on the lateral side of the tibia. That's why the introtious membrane is supposed to be on the lateral aspect of the tibia. ठीक है? Then that's why we are saying that the lateral border of the tibia is the introtious border. And likewise we have got, ठीक है, इसको हम जल्दी कवर कर लेते हैं. We have got three surfaces. The posterior surface, of course, posterior surface उस तरफ पे present होगा. Apart from that, we have got the lateral surface and the medial surface. I think this thing is simple ना, कि ये हमारा lateral side है tibia का, this is the medial side, so this is supposed to be the lateral surface ना, the lateral surface between the anterior and the lateral border, and the medial surface between the anterior and the medial border, and the posterior surface between the medial and the lateral borders है ना, that is the posterior surface. Now the thing that is important here is that we have got this line. If we have a look at the posterior part of the tibia, here we can see this particular line that is called as the soleal line. Soleal line जो होता है, soleal line has the significance. Of course, अगर नाम soleal line है, can anyone tell me there is a muscle जो कि same नाम से जाती है? Soleus है ना?
Soleus.
हाँ, there is this muscle that is called as soleus. So it means simply we have got the soleus muscle. The origin of that muscle is just on the soleal line, or you can say below the soleal line. तो soleal line के नीचे से हमारा we have got the origin of the soleus muscle, and then can anyone tell me the insertion of the soleus? Insert कहाँ पे होती होगी? Does anyone remember? Tendoachilles ना, हाँ, the Achilles tendon. On the tendoachilles, or we can say on the posterior part of which bone? Which bone of the foot? Of the calcaneus ना? Of the calcaneus, the posterior part of the calcaneus. So when we talk about the tendoachilles, we have got three muscle insertion, तीन muscles का insertion होता है in the tendoachilles. किसी को याद है? We have got three muscles which are
gastrocnemius, soleus.
हाँ,
Gastrocnemius,
gastrocnemius, soleus, and not tibialis posterior, the plantaris. The plantaris, soleus, and gastrocnemius. Gastrocnemius and plantaris, gastrocnemius and soleus को हम gastrosoleus भी collectively बोल देते हैं. We have got the gastrosoleus, or you can say the gastrocnemius, then the soleus, and then the plantaris. These three muscles are getting inserted into the tendoachilles on the posterior part of the calcaneus. ठीक है? The tendoachilles or the Achilles tendon. ठीक है? Plantaris अगर आपको दिखाऊं मैं, ये है plantaris muscle. ये देखो, it is coming from the lateral condyle. ठीक है? देखो, okay, here we can see from the lateral condyle of the femur हमारी जो muscle आती है, we will talk about this muscle properly जब हम muscles के बारे में बात करेंगे. But here we can see this is the origin of the plantaris is on the lateral condyle all the way. देखो हमारा ये इस तरह से जा रही है, and उसके बाद getting inserted into the tendoachilles. Likewise we can see there is another muscle that is soleus. Soleus हमने देख लिया. It originates below the soleal line. Here we can see this is the soleus and soleus muscle na, and getting inserted into the tendoachilles again. And we have got another muscle that is the gastrocnemius. Gastrocnemius, देखो gastrocnemius has got two heads. दोनों मतलब from the lateral as well as from the medial condyle, दोनों condyle से originate होता है. एक बार मैं यहाँ पे दिखाता हूँ. Gastrocnemius muscle. Okay, तो ओके यहाँ पे हम देख सकते, देखो दोनों कॉन्डाइल से, लैटरल एंड मीडियल, दोनों कॉन्डाइल से हमारा ऑरिजिन होता है गैस्ट्रोनीमियस का, एंड देन अगेन गेट्स इंसर्टेड इनटू दिस पर्टिकुलर इनटू द टेंडोएक्लिस. ठीक है? तो गैस्ट्रोनीमियस का दोनों हेड से ऑरिजिन हो रहा है, प्लांटेरिस का सिर्फ लैटरल हेड से ऑरिजिन हो रहा है, एंड सोलियस का हमारा बिलो द सोलियल लाइन, कुछ ऐसा है ना, ये हमारा सोलियस मसल होती है. ठीक है? एंड तीनों का हमारा इंसर्शन इनटू द टेंडोएक्लिस. एंड कैन एनीवन टेल मी देयर इज अ कंजेनाइटल कंडीशन जिसमें वी सी देयर इज अ शॉर्टनिंग ऑफ द tendoachilles? CTEV, that is full form बता सकते हो? लंबा चौड़ा है.
congenital
polio.
हाँ, okay. In case of polio,
Sir, polio.
poliomyelitis के केस में majorly we can see the condition is happening, the deformity is happening on the hip joint, जहाँ पे we see कि वो lateral rotation उसमें चला जाता है. And but majorly it is the मतलब these are the muscles ना which are getting affected majorly in polio. ठीक है? But अगर if we talk about CTEV, okay, but in case of CTEV we see congenitally the foot is in the plantar flex position ना. In that case there is a shortening of the tendoachilles and because of that we need to increase the length of the tender Achilles so as to bring the foot back into its normal position ना. Does anyone
सर
remember
और CP cases भी नहीं होता ना सर?
किसमें? हाँ
सर CP cases
हाँ
cerebral
सीपी
palsy.
अगर स्पास्टिक सीपी है तो उस केस में हम देख सकते हैं. देखो द थिंग इज दैट सीपी के केस में या फिर अगर इन कंडीशन की अगर हम बात करते हैं ना तो प्रिसाइसली वी नीड टू टॉक अबाउट द मसल्स बिकॉज मसल्स आर द वंस विच आर गेटिंग अफेक्टेड मेजरली. ऑफकोर्स अगर एक प्रोलॉन्ग पीरियड ऑफ टाइम के लिए फुट अगर हमारा प्लांटर फ्लेक्स पोजिशन में है बिकॉज ऑफ द काफ मसल्स जो कि हमारे कॉन्ट्रैक्टेड जो भी स्टेट में स्पास्टिक स्टेट में है तो उसकी वजह से ऑफ कोर्स वी विल सी सम डिफॉर्मिटी इन द लिगामेंट एज वेल, सॉरी इन द टेंडो एक्लिस एज वेल. लेकिन हाँ ठीक है उसमें उसमें हम देख सकते हैं लेकिन उसके लिए द फुट नीड्स टू बी इन दैट पर्टिकुलर टाइप ऑफ डिफॉर्मिटी फॉर अ कंसिडरेबल पीरियड ऑफ टाइम. बट लेकिन मेजरली अगर हमें टेंडो एक्लिस की शॉर्टनिंग अगर हमें देखनी है तो हाँ फिर वो हम CTV में देख सकते हैं. बट यूर राइट कि हाँ मतलब अगर हम उसमें बट मेजरली इट इज़ द मसल्स विच आर मेजरली अफेक्टेड अगर हम पोलियोमाइलिटिस की बात करें या फिर उसकी बात करें. पर पोलियो में तो हमारा फ्लैसिड होता है. पोलियो में तो फ्लैसिड पैरालिसिस होता है ना. पोलियो हमारा लोअर मोटर न्यूरॉन लीजन है. CP हमारा अपर मोटर न्यूरॉन लीजन है जिसमें स्पास्टिसिटी इंक्रीज करती है. ठीक है. एंड और क्या चीज़ है हाँ ठीक है हाँ एक कोई सर्जिकल कोई वो किसी को ध्यान में सर्जिकल मेथड ऑपरेटिव मेथड
Plasty.
जेड प्लास्टी.
Zatobi.
हाँ जेड प्लास्टी.
Yeah.
ओके हाँ जेड प्लास्टी में मेजरली वी कैन गो फॉर जेड प्लास्टी. लेट्स से if there was a child with CTV and that child doesn't came to the hospital in the initial phases of the condition and after some time we saw the condition and now the person wants the condition to get treated. In that case we need to go for Z plasty जहाँ पे we attach additional that thing you can say graft something like that which increases the length of the tender Achilles so as to bring the foot back into normal position. अगर tender Achilles की length छोटी होगी I hope everyone is clear with this thing कि tender Achilles की length अगर कम है तो उस केस में foot is supposed to be in the plantar flexion. इसमें तो किसी को डाउट नहीं है.
No, sir.
देखो ये है ना ये हमारा फुट है. टेंडो एक्लिस हमारा यहाँ प्रेजेंट है ना पोस्टीरियरली. अब टेंडो एक्लिस की शॉर्टनिंग अगर है तो फुट इज सपोज टू बी इन द प्लांटर फ्लेक्शन ना. उस केस में प्लांटर फ्लेक्शन मींस जहाँ पे एंगल बिटवीन द डॉर्सम ऑफ द फुट एंड द शिन इज इंक्रीजिंग दैट इज प्लांटर फ्लेक्शन ना. डॉर्सल फ्लेक्शन में इसका अपोजिट है. ओके इसके अलावा और भी ऑपरेटिव मेथड्स होते हैं. कौन सा होता है पोस्टीरियर मीडियल रिलीज होता है ना. एंड इसके अलावा ट्रिपल आर्थ्रोप्लास्टी भी हम कर सकते हैं इन केस ऑफ CTV. लेट्स से इफ देयर इज एनी इफ द कंडीशन इज मच वर्स इन दैट केस वी कैन गो फॉर ट्रिपल आर्थ्रोप्लास्टी एज वेल. ओके तो वी विल टॉक अबाउट दैट. बट हे वी हैव गॉट दिस थिंग क्या चीज this soleal line and below that we have got the soleus muscle. Above the soleus muscle we have got the triangular muscle present here that is called as that popliteus na. We have got the popliteus muscle which is present above the soleal line, triangular shaped muscle here, and the popliteus has its attachment on the lateral condyle of the femur. ठीक है तो हमने plantaris भी देख लिया. Plantaris has its attachment on the lateral condyle and also it is the popliteus also which has got its attachment on the lateral condyle which provides knee joint unlocking. ठीक है knee unlocking में function करता है. ठीक है. Along with that we can see we've got another line on the posterior part that is this line that is the vertical ridge. ठीक है we have got this triangular area and made by the soleal line, and again we can see this vertical ridge, and that provides this vertical line just below the soleal line. It provides the attachment for flexor digitorum longus. ठीक है just remember the name of the muscle, that is the flexor digitorum longus, this one. ठीक है we can see that this muscle has its origin or its attachment on this vertical ridge, and we can talk about the origin of the soleal line of the soleal muscle on the soleal line. ठीक है and on this triangular area we have got the that muscle, the popliteus muscle. ठीक है I hope we are done with this thing, the proximal part of the not the proximal part but the shaft of the tibia. ठीक है anteriorly we have seen the shaft, posteriorly में proximal 1/3 पे it is important. ठीक है and apart from that we have talked about, I think this is pretty simple ना. इसमें ज़्यादा कुछ I don't think कि ज़्यादा कुछ चीज़ें, but एक दो चीज़ें हमें कुछ ना कुछ नई सीखने को मिल रही है यहाँ पे. बाकी more or less it is simple. जब तक हम इसके बाद इसके इसके आगे प्रिसाइजली बस एक बार ये बोन्स है, उसके बाद फिर फिबुला है एंड फुट की बोन्स है. फुट में थोड़ा बहुत आर्चेज है, एंड आफ्टर दैट वंस वी आर डन विद दैट, आफ्टर दैट वी विल बी टॉकिंग अबाउट द मसल्स. तो वहाँ पे काफ़ी इंटरेस्टिंग होगा. उसके बाद जब इसका फंक्शनिंग में हम आएंगे बायोमैकेनिक्स में, वो चीज़ काफ़ी इंटरेस्टिंग होने वाली है, बिकॉज अब हमें स्ट्रक्चर्स के बारे में पता है. नाउ वी हैव टू टॉक अबाउट द थिंग कि वो फंक्शन कैसे करते हैं आपस में. ठीक है, ओके. तो ओके, शाफ्ट की हमने बात कर ली. एंड नाउ हाँ, देर इज दिस वन थिंग दैट इज कॉल्ड एज इंट्रा ऑशियस एक्सिस. तो व्हेन वी आर टॉकिंग अबाउट द शाफ्ट ऑफ टीबिया, we are supposed to talk about the intraosseous axis. Intraosseous axis means we are trying to access something ना, बोन के अंदर हम कोई चीज़ किस चीज़ तक पहुंचना चाह रहे हैं, मतलब किस चीज़ को एक्सेस करना चाह रहे हैं. तो बेसिकली व्हाट इज इंट्राओशियस एक्सेस? लेट्स से इन एनी कंडीशन जहाँ पे हमारा वेस्कुलर सिस्टम इनसाइड द बोन, इफ दैट इज अफेक्टेड, यू नो, वी हैव गॉट दिस कैनाल दैट इज कॉल्ड एज वोक्समैन कैनाल. नाम सुना सबने, वोक्समैन कैनाल, विच इज प्रेजेंट, है ना. वोक्समैन कैनाल होता है. इसके अलावा हेवर्जन कैनाल होता है. इसके स्ट्रक्चर्स हम पढ़ेंगे ऑर्थो में प्रॉपर्ली, लेकिन हम देख सकते हैं कि वोक्समैन कैनाल, हेवर्जन कैनाल प्रेजेंट होते हैं, जिसके अंदर हमारा वी हैव गॉट दिस वेस्कुलर द आर्टरीज इन द वेन्स which provides the nutrition to the inner part of the bone, you can see. ठीक है, तो but here we can see कि let's say because of any condition the vascular system is affected, है ना, or you can say in case of any emergency setting. ठीक है, and now we want to administer some fluids, or let's say some blood products or something into the bone marrow. In that case we access the bone, the inner part of the bone, and that process is called as intraosseous access. ठीक है, in the case where the vascular system is affected, or in case of emergency condition, we need to access the bone marrow so as to administer some fluids or something. Again इसके बारे में हम बात करेंगे. We have got some fluids like क्रिस्टलाइड्स होते हैं, कुछ कोलाइड्स होते हैं, जो कि हमारा हम इंसर्ट करते हैं इनटू द बोन मैरो, है ना, इन केस ऑफ एमरजेंसी कंडीशन, और certain medications which we can administer. So for that we go for the intraosseous access. Now there are two different sites in the shaft of tibia where we can go for the intraosseous access. If you remember, I talked about this, that the metaphyseal region of a bone is the region where we have got the vascular system which is densely present there. So for sure we have to go to the region of the bone जहाँ पे metaphyseal region है, मतलब on the metaphyseal region हमें we have to locate that region, and then we can go for the intraosseous access. So it means either this particular part of the bone or this particular part of the bone. We have to access these either of these regions, and then we can administer these medications or these fluids or these blood products to the inner part of the bone or the bone marrow. Okay, so we can see here we have got two different sites in the tibia where we can go for the intraosseous access. Either it is the anterior medial surface, 2 to 3 centimeter below the tibial tuberosity. Okay, anterior medial, this particular part 2 to 3 centimeter below the tibial tuberosity, or you can say this particular part, the part proximal to the medial malleolus, this particular part, the part proximal to the medial malleolus, either this part or this part. Okay, we can access either of these regions when we are talking about the shaft of tibia, and we can use these regions for intraosseous access so as to administer these fluids and the medications to the inner part of the bone in the emergency condition where the blood supply or the blood vessels are affected in this bone. Okay, that is called as intraosseous access. Okay, I hope till now we are clear with the intraosseous access.
Yes, sir.
Okay,
Yes.
and there can be okay, we can see ki because of intraosseous, sometimes we can see ki there can be some conditions like osteomyelitis. We will talk about osteomyelitis and compartment syndrome. इसको हम डिटेल में बात करेंगे, कंपार्टमेंट सिंड्रोम की एंड ऑस्टियोमाइलिटिस, बट वी कैन सी these are some of the conditions that we can talk about in the cases जहाँ पे हम intraosseous access कर रहे हैं. ठीक है, and because of intraosseous access I use the term, एक term मैंने introduce किया था, that was iatrogenic ना. We can say that these conditions can be iatrogenic in nature. It means these conditions are occurring in the patient because of any medical intervention. Since there is a medical intervention, because of that there is this condition that is happening in the patient, and we can say that the origin of these conditions in this particular case are supposed to be iatrogenic in nature. ठीक है, सबको ये टर्म ध्यान है, iatrogenic, ठीक है, क्वेश्चन में
Yes,
आ
sir.
सकता है, तो जस्ट रिमेंबर द
Yes,
टर्म,
sir.
ठीक है. And then let's talk about the distal part, that is the distal part of the tibia. तो distal part में just the way we talked about the distal part of the radius, वैसे हम देख सकते हैं, we have got an anterior, तो यहाँ पे we can see this is the posterior surface, on the opposite side we have got an anterior surface, the medial and the lateral surface, and then we have got an inferior surface as well. Inferior surface, of course, for the attachment of, there is one bone which is attached on the inferior surface of
Talus.
tibia, that is the talus, है ना. तो along with the tibia, along with the fibula, and the tibia, ठीक है, they make this inverted U-shaped structure, है ना. And along with the talus they make a joint. Can anyone tell me the name of that joint? The joint between,
Talocrural
that is called as talocrural joint, no? That is called as talocrural joint, the joint between the talus present here, the tibia, and the fibula, है ना. And that is called as the talocrural joint, or we can call it as the ankle joint, ना, as the actual ankle joint, ठीक है, ankle joint, that is the talocrural joint. Okay, ठीक है, that is the distal part of the tibia. And here we can see it is though both these structures, they are making the inverted, this U-shaped structure, and we have got the talus bone here and makes the talocrural joint made by these three bones, ठीक है. This is the lateral malleolus, a bit distal to the medial malleolus. Medial malleolus is more proximal. And okay, then we are done with the distal part of the tibia. And okay, again we can see that if there is any fracture of the shaft of tibia, अगर कोई fracture of the shaft of tibia, just like the way we talked about this in the shaft of femur, same thing we can talk about here also, about the high energy trauma and the low energy trauma. Low energy trauma where we have to talk about the fracture happening in the elderly, and in the high energy trauma we can talk about the younger population. And again we can see, because of weight bearing, since even though we have reduced the bone, we have done the bone reduction, still if the person bears weight, there can be a prevalence of the bone getting disaligned again, है ना. And that because of that, again we can see, so it means that we can go for certain type of procedures there. We will talk about those procedures again in the ortho, but we can see ki, there is a high prevalence of disalignment of the bone fragments even after formation of the callus, when we ask the person to bear weight on the leg, ठीक है. तो वो उसके chances तो कभी होते हैं, तो उसमें फिर हम एक particular method we go for that, and we will talk about that in ortho. Okay, I hope till now we are done with the tibia, the proximal part, the shaft, the distal part, है ना, the articulating surface, Gerdy's tubercle हमने discuss किया, tibial tuberosity हमने discuss कर लिया, ठीक है. Okay, now the fibula it is more or less it is a simple bone. Simply इसको हम ज़्यादा डिटेल में नहीं पढ़ते, यहाँ पे हम एक चीज़ देखते हैं. First of all, if we talk about the tibia and the fibula is supposed to be homologous to the ulna. Why homologous to ulna? Because here we can see the fibula is present on the side of the little finger, है ना. And just like that we can see in the forearm, the ulna is present on the side of the little finger, ठीक है. And that's why we can say that the fibula is homologous to ulna, and the tibia is homologous to radius, ठीक है. Just remember this. Of course, humerus is homologous to the femur, है ना. Okay, and does it bear any weight? The fibula, does it contribute in weight bearing? Oh, it doesn't contribute in the weight bearing, na. It participates only, it provides site for muscle attachment. We can see there are various muscles which are attached on the fibula. One of the most commonly that we can see on the proximal part, on the head of the fibula, we can see that is which muscle? That is the biceps femoris. The insertion of the biceps femoris we can see on the head of the fibula, okay. Apart from that, there are various other muscles also we can see they have their attachment to the fibula. So it provides a site of attachment, but doesn't participate in weight bearing. Also, if we talk about the grafting, can anyone tell me grafting क्या होता है? What is bone grafting?
Taking bones from either pelvic or fibula and inserting fractured
in the fractured part of, है ना. So it means that grafting simply means that we are taking some fragment of bone, be it from the same person or from another person or from some other animal. So we call it as autogenous grafting or allogenous grafting, or whatever, like तीसरा क्या होता है, xenogenous graft, something like that. So we can call it different type of grafting, but we can say that if we take a bone fragment and then we place it on the part of the fractured bone, in that case we can say that that is called as bone grafting, है ना. तो हाँ, so we can say that if we want a bone graft, I think fibula is one of the most commonly looked bone that we can talk about if we want a bone graft, because of course इसका कोई function नहीं है in weight bearing. So if we take some part of the fibula for as a bone graft, there won't be much problem in the person ना. तो we can use fibula as a common site for taking the bone, some part of the bone as a graft, है ना. And apart from that, जैसे आपने बताया कि we can take some part of the ilium as well, ठीक है. इलियम या इलियक क्रस्ट से भी हम कुछ पार्ट ले सकते हैं एज अ बोन ग्राफ्ट. इलियक क्रस्ट से मेजरली मैंने इसके बारे में बात करी थी कि नहीं करी थी, एक ग्राफ्ट के बारे में मैंने बात करी है पहले?
नहीं सर,
नहीं करी है, इस बैच में नहीं करी है मैंने, आई थिंक. ठीक है, तो मतलब ये होता है कि अगर इलियक क्रस्ट से अगर हम बोन ग्राफ्ट लेते हैं तो डैट वी कैन यूज़ फॉर ऑस्टियोजेनिक पर्पस. लेट्स से हमारा लेट्स से फीमर है, फीमर में हमारा कोई भी पैथोलॉजिकल कंडीशन हुआ, बिकॉज ऑफ डैट दिस मच सेगमेंट ऑफ द फीमर जस्ट गॉट डिजॉल्व, है ना. इतना पार्ट ऑफ द फीमर जो है इट डिसअपियर्ड बिकॉज ऑफ एनी कंडीशन. In that case, if now we want some bone graft and we want to attach it, we want to add it in this part of the fractured femur, in that case what we do, we will take some part of the cortical as well as the cancellous, the outer part of the bone and the inner part of the bone from the ilium. Okay, we will take that and then we will place it here and then we will let that bone to ossify. उसका ossification process को हम होने देंगे, so that the bone develops on its own and it covers up the dissolved part of the bone. ठीक है, तो उसके लिए we take it here. But let's say कहीं और पे अगर fracture है, in that case we just want some part of the graft so as to increase the amount of strength. हमें कहीं पे strength improve करनी है किसी bone की, उसके लिए हमें अगर चाहिए तो in that case we can take bone from the fibula in that case. ठीक है, तो उस केस में हम fibula so as to improve the strength we can take graft from the fibula, and for the osteogenic purpose, if we want to take the graft we can take it from the iliac crest, है ना. And we have to take both the cortical as well as the cancellous part of the iliac crest. ठीक है, okay, I hope till now we are clear. ये point सबको clear हुआ?
Yes sir.
Okay, ठीक है. And okay, we can see where this thing, the fibula, along with the tibia, it makes just like the radial joint, it makes the proximal and the distal tibiofibular joint. And ठीक है, and we can talk about the ankle joint, that is the talocrural joint. Okay, now my question is कि we have got the proximal tibiofibular joint. If we are talking about the knee complex में हमारा proximal tibiofibular joint participate करता है कि नहीं करता है? भाई बताना चाहिए.
नो सर,
कैन यू टेल मी कि कौन कौन से जॉइंट्स हमारे नी कॉम्प्लेक्स में प्रेजेंट होते हैं?
टिबिया, फीमर एंड द पटेला.
Tibia, femur and the patella. It means the tibiofemoral joint and the patellofemoral joint, but not the proximal tibiofibular joint. It means हमारा यहाँ से यहाँ तक है ना, इतना पार्ट जो है that is part of the knee joint complex, but except it means proximal tibiofibular joint can be part of the ankle complex, but not part of the knee complex. ठीक है, ये चीज़ ध्यान रखना. And ठीक है, just like the way fibula is a simple bone, तो fibula में just we will see the proximal, the shaft and the distal part. Proximal part में we have got the head of fibula, जो कि simply we can see it is the site of attachment for various muscles, majorly this thing, the bicep femoris, the shaft. Yeah, the bicep femoris. The shaft is we can call this part as the uppermost part. Here we can see the uppermost part of the fibula. We can call it as the styloid process of fibula. ये चीज़ ध्यान रखना. Otherwise, in the rest of the bones, we name the distal most part of that bone as the styloid process. जैसे हमने radius में बात करी थी. We said that the distal most part of the radius was the styloid process of the radius. ना, but यहाँ पे we can see that the proximal most part of the fibula is called as the styloid process of the fibula. It is present on the apex of the head of fibula. ठीक है, here this is the styloid process of the fibula. ठीक है, then the shaft, it is more or less triangular in shape. ठीक है, we have got the anterior, lateral and the posterior borders. Anterior border then the lateral border and the posterior border, and then we can see that we have got the distal part which makes the distal which makes the lateral malleolus. It is simple, ठीक है. यहाँ पे सिर्फ बेकार में एक के बाद एक स्लाइड में इतना कुछ लिखा हुआ है, but I think this is more or less simple. And then we have got this interosseous membrane again, which is present here on the lateral border of the which is attached to the lateral border of the tibia, ठीक है. And ठीक है, again this thing is clear. I hope we are clear with the fibula. फिबुला क्लियर है, फिबुला एंड टीबिया हमारा क्लियर है, ठीक है. एंड उससे पहले हमने फीमर की बात कर ली, फीमर भी हमारा क्लियर है अभी तक. एंड उसके बाद नाउ लेट्स टॉक अबाउट द पटेला. पटेला थोड़ा सा टाइम हो गया, थोड़ा सा लेट हो गया, बट चलो थोड़ा बहुत डिस्कस कर लेते हैं पटेला के बारे में. पटेला में हमें क्या चीज़ देखनी है. ऑफ कोर्स सबसे पहले हम इसको सेसमॉइड बोन बोलते हैं ना. कोई बताएगा सेसमॉइड बोन इसको हम क्यों बोलते हैं?
Because it is made up of tendon.
हाँ, any bone over which tendon
yes,
pass.
वो टेंडन से origin होता है सर. वो origin sequence इसमें रहता है.
हाँ, it means कोई भी bone अगर एक tendon के नीचे रहती है ना, या फिर we can say कोई भी if there is any tendon that passes over a particular bone, we call that bone as a sesamoid bone, ठीक है. तो कोई बताएगा एक और एग्जांपल sesamoid bone का? पिसिफॉर्म. हाँ, है ना. कौन सा? फ्लेक्सर कार्पाई अल्नारिस, आई गेस अल्नारिस ना. हाँ, यही होती है. तो दैट पर्टिकुलर मसल इट पासेस ओवर द पिसिफॉर्म बोन, है ना. पिसिफॉर्म बोन इज पार्ट ऑफ द कार्पल बोन्स ना. तो इट इज प्रेजेंट ऑन द अल्नर मोस्ट साइड. तो दैट स्मॉल यू कैन से पी शेप्ड है ना. पी शेप्ड जो पी का जो ग्रेन होता है, तो उस शेप का बोन होती है. इट मीन्स कि स्मॉल बोन है, उसके ऊपर से over that we can see the flexor carpi ulnaris that is passing, and that's why we are calling it as the sesamoid bone. But the largest sesamoid bone in the body that is supposed to be the patella, ठीक है. अब यहाँ पे सिर्फ मैं एक चीज़ समझाना चाहता हूँ, बट टाइम अलो नहीं कर रहा. ओके, सिंपली थोड़ा सा एक दो लाइन में हम देख लेते हैं, उसके बाद इसको हम प्रॉपर्ली कल भी डिस्कस करेंगे. यहाँ पे what we can see that of course we have got this is the anterior part, of course this is the posterior part. अभी हम इस वाली पिक्चर को अगर हम कंसिडरेशन में लेते हैं, we have got the quadriceps muscle which is present here, है ना. Of course quadriceps tendon present है, and the tendon passes over the patella and then gets attached on this particular part of the tibia. इसका नाम क्या था, कोई बताएगा? tibial tuberosity. This is the tibial tuberosity. तो अभी हम इसको sesamoid bone बोल रहे हैं because the quadriceps tendon it passes over the patella. Now let's say अगर patella present नहीं होता, if it was absent, in that case the quadriceps tendon would have passed along the anterior part of the femur and then would have attached on the tibial tuberosity, है ना. in the case जहाँ पे patella absent होता. यहाँ तक clear है?
Yes, sir.
Okay.
Yes, sir.
Okay, तो now what we can see, अगर हमारा यहाँ पे patella present है, तो it means if we have to talk about the movement arm किसका? quadriceps muscle का. तो उसके लिए फर्स्ट ऑफ ऑल मूवमेंट आर्म अगर हमें देखना होता है, तो वी हैव टू टॉक अबाउट अ स्ट्रक्चर जहाँ पे कहीं ना कहीं एफर्ट लग रहा है, कहीं ना कहीं फलक्रम है या फिर एक्सिस है, और कहीं पे हमारा लोड लग रहा है ना. तो वी कैन सी सिंपली कि अगर हम इस नी जॉइंट की बात करते हैं, लेट्स टेक दिस पर्टिकुलर पॉइंट एंड वी कैन से दैट दिस पर्टिकुलर पॉइंट इज द एक्सिस जिसके अराउंड हमारा नी जॉइंट जो है वो फ्लेक्शन या एक्सटेंशन मूवमेंट करता है. एम आई राइट? ये पर्टिकुलर पॉइंट होगा. एंड एक्सिस कौन सा होगा नी जॉइंट फ्लेक्शन एक्सटेंशन के लिए? एक्सिस कौन सा होगा, कोई बताएगा? इट विल बी द फ्रंटल एक्सिस ना.
Yes, sir.
फ्रंटल एक्सिस है ना. फ्रंटल एक्सिस के अराउंड हमारा नी जॉइंट फ्लेक्शन एंड एक्सटेंशन होता है ना. तो नाउ व्हाट आई एम सेइंग कि सेंटर पॉइंट ऑफ द नी जॉइंट यहाँ से ये हमारा एक्सिस होगा, इसके थ्रू हमारा राइट टू लेफ्ट जो एक्सिस पास करता है दैट इज द फ्रंटल एक्सिस, जो कि इस पर्टिकुलर पॉइंट के थ्रू पास करेगा. ओके, नाउ वी कैन से दैट दिस इज द एक्सिस दिस इज द सेंटर पॉइंट ऑफ द नी जॉइंट या फिर फल्क्रम हो गया. एंड अगर हमें यहाँ पे क्वाड्रिसेप मसल की बात करनी है विच इज प्रोवाइडिंग नी जॉइंट एक्सटेंशन, ऑफ कोर्स क्वाड्रिसेप यहाँ से आ रही है getting attached on the anterior part of the tibial tuberosity. Now there is contraction of the quadricep muscle, contract करती है and tibia को पकड़ के अपनी तरफ लेकर आ रही है ना. It is trying to bring the tibia towards itself. तभी हमारा knee joint पे extension हो रहा है. तो इसका मतलब effort हम कहीं बोल सकते हैं कि effort हमारा कहीं यहाँ पे होगा upwards. quadricep muscle यहाँ पे आ रही है, तो it means quadricep का contraction is trying to bring the tibia anteriorly, है ना, और into knee joint extension. It means I can say कि इस कहीं पर्टिकुलर पॉइंट पे हमारा ऊपर की तरफ मैं एक एरो बना सकता हूँ फॉर द फोर्स फॉर द एफर्ट ना, जो कि हमारा क्वाड्रिसेप मसल लगा रही है, ठीक है.
Yes, sir.
आई होप टिल नाउ वी आर क्लियर है ना. ओके. एंड हाँ वी कैन सी कि समहाउ समवेयर हेयर वी कैन सी कि हमारा जो टीबिया है वो लोड की तरह काम कर रही है, बिकॉज लोड हमारा टीबिया का है, जिसके अगेंस्ट हमें हमारा क्वाड्रिसेप को कॉन्ट्रैक्ट करना है सो एज टू प्रोवाइड नी जॉइंट एक्सटेंशन. नाउ व्हाट वी कैन सी, अगर अगर नाउ इफ वी आर सपोज टू टॉक अबाउट द मूवमेंट आर्म फॉर द एफर्ट, या फिर जिसको हम सिंपली एफर्ट आर्म बोलते हैं. एफर्ट आर्म सिंपली मीन्स कोई भी अगर मूवमेंट आर्म की अगर हमें बात करनी होती है तो इट मीन्स वी हैव टू टॉक अबाउट द शॉर्टेस्ट डिस्टेंस विच इज़ बिटवीन द एक्सिस एंड द अदर पार्ट ऑफ दैट लिवर ना. या तो हमारा एफर्ट होगा या फिर लोड होगा, है ना. एक्सिस से लोड तक हमारा लोड आर्म, या फिर वी कैन से मूवमेंट आर्म ऑफ द लोड, एंड एक्सिस से एफर्ट तक हमारा एफर्ट आर्म या फिर मूवमेंट आर्म ऑफ द एफर्ट, है ना. तो यहाँ पे अगर हमें एफर्ट आर्म अगर हमें कैलकुलेट करना है, या फिर let's say अगर हमें मूवमेंट आर्म ऑफ द एफर्ट कैलकुलेट करना है, एफर्ट हमारी कौन सा चीज़ लगा रही है, मसल लगा रही है ना. एफर्ट जो है वो हमारी क्वाड्रिसेप मसल लगा रही है. इट मीन्स लेट्स से हमारा क्वाड्रिसेप मसल यहाँ से होते हुए जा रही है, तो इट मीन्स द शॉर्टेस्ट डिस्टेंस बिटवीन द एफर्ट एंड द एक्सिस अगर मैं यहाँ पे बनाना चाहूँ, इट विल बी समथिंग लाइक दिस ना, यहाँ से लेके यहाँ तक, है ना. आई होप आई एम क्लियर. क्वाड्रिसेप मसल का जो जहाँ पे प्रेजेंट है, जो कि एफर्ट लगा रही है, तो अगर मैं एफर्ट आर्म के लिए अगर मैं लाइन बनाना चाहूँगा, इट इज़ सपोज टू स्टार्ट समवेयर हेयर एक्सिस से, एंड इट शुड गो ऑल द वे अप टू दिस पर्टिकुलर पॉइंट यहाँ तक, क्योंकि हमारी क्वाड्रिसेप यहाँ से जा रही है ना. इतना सबको समझ आया?
Yes, sir.
ओके. नाउ लेट्स से मैंने पटेला को रिमूव कर दिया. अगर पटेला को रिमूव किया इन दैट केस, क्या हमारी क्वाड्रिसेप इन दैट केस विल इट बी लाइक दिस? नहीं ना. इन दैट केस, है ना, हमारी क्वाड्रिसेप यहाँ से पास करेगी. तो व्हाट शुड हैपन टू द मूवमेंट आर्म और द एफर्ट आर्म? इट शुड इंक्रीज और डिक्रीज?
Decreases.
इट शुड डिक्रीज ना. तो अगर मूवमेंट आर्म हमारा क्वाड्रिसेप के कॉन्ट्रैक्शन के लिए, नॉट क्वाड्रिसेप जो एक्सटेंशन टॉर्क प्रोड्यूस कर रहा है, उस टॉर्क के लिए जो मूवमेंट आर्म है या फिर क्वाड्रिसेप का जो एफर्ट आर्म है वो डिक्रीज हो जा रहा है बिकॉज ऑफ द एब्सेंस ऑफ पटेला. तो इट मीन्स अब अगर पटेला हमने रिमूव कर दिया, तो इन दैट केस नाउ इफ़ यू वांट टू प्रोड्यूस नी जॉइंट एक्सटेंशन, तो इन दैट केस क्वाड्रिसेप को ज़्यादा फोर्स प्रोड्यूस करना पड़ेगा ना, बिकॉज वी नो कि क्या कहते हैं, टॉर्क का फॉर्मूला क्या होता है? कोई बताएगा टॉर्क का फॉर्मूला क्या होता है? टॉर्क का फॉर्मूला इट इज़ फोर्स इनटू मूवमेंट आर्म ना.
यस सर.
हाँ, इट इज़ फोर्स टाइम्स मूवमेंट आर्म, ठीक है. तो हमने देखा यहाँ पे कि अगर पटेला हमने रिमूव किया है, तो इन दैट केस मूवमेंट आर्म क्या हुआ? मूवमेंट आर्म बढ़ा कि कम हुआ? मूवमेंट आर्म इट डिक्रीज, कम हुआ ना, डिक्रीज हुआ. तो मूवमेंट आर्म पहले हमारा क्वाड्रिसेप का कहीं यहाँ तक था, बिकॉज क्वाड्रिसेप टेंडन हमारा यहाँ से पास कर रहा था. बट नाउ सिंस वी हैव रिमूव द पटेला, नाउ वी कैन सी द क्वाड्रिसेप टेंडन इट इज पासिंग समवेयर हेयर, एंड द मूवमेंट आर्म और द शॉर्टेस्ट डिस्टेंस बिटवीन द एफर्ट जो कि हमारे यहाँ प्रेजेंट होगा, जो कि क्वाड्रिसेप मसल का है, एंड द एक्सिस ऑफ दिस जॉइंट, वो डेट विल डिक्रीज, है ना, वो डिक्रीज हो जाएगा. अब अगर टॉर्क के लिए हमारा फोर्स इनटू मूवमेंट आर्म डिक्रीज हो गया, तो फोर्स हमें ज़्यादा करना पड़ेगा ना, ताकि हम सफिशिएंट अमाउंट ऑफ टॉर्क प्रोड्यूस कर पाए, ताकि हमारा नी जॉइंट एक्सटेंशन में आ पाए. टॉर्क हमें कम करने की ज़रूरत नहीं है. अगर हमें नी जॉइंट एक्सटेंशन करना है या फिर कोई भी अगर मूवमेंट करना है किसी जॉइंट पे, एक मिनिमम थ्रेशोल्ड टॉर्क होता है, एक मिनिमम वैल्यू की टॉर्क है, उतना हमें टॉर्क अटेन करने की ज़रूरत है, हम तभी उस जॉइंट पे वो रेंज ऑफ मोशन कर पाएंगे ना. अगर उतना टॉर्क हम पहुँच ही नहीं पाए, उतने टॉर्क तक अगर हम पहुँच ही नहीं पाए, तो इन डैट केस कोई वहाँ पे मूवमेंट होगा ही नहीं. तो इट मीन्स टॉर्क अटेन अगर हमें करना है उतना, या तो हमें मतलब फोर्स इनटू मूवमेंट आर्म, या तो हमें फोर्स को बढ़ाना पड़ेगा या फिर मूवमेंट आर्म को बढ़ाना पड़ेगा. तो यहाँ पे हमने देखा कि मूवमेंट आर्म तो कम हो गया बिकॉज ऑफ द एब्सेंस ऑफ पटेला. तो नो वी आर सपोज टू इंक्रीज, क्या हमें फोर्स इंक्रीज करना पड़ेगा क्वाड्रिसेप का, ना तो क्वाड्रिसेप हैज टू कॉन्ट्रैक्ट मोर स्ट्रांगली, है ना. तो एंड if the quadriceps fails to contract that strongly, if there is absence of the patella, in that case we can see a condition that is called as extension lag. ठीक है, उस केस में हमें एक्सटेंशन लैग देखने को मिल सकता है. ठीक है, वी विल टॉक अबाउट दैट. इसके बारे में हम फिर कल प्रॉपर्ली बात करते हैं, अभी टाइम हो गया, तो फिर कल हम पटेला को प्रॉपर्ली कवर करते हैं, उसके बाद वी विल कम अप टू द, ठीक है, ये भी इंपॉर्टेंट हो जाएगा. ओके सर, तो इसको हम, हाँ
सर, एक पटेला पुली जैसे एक्ट करता है ना सर क्वाड्रिसेप्स मसल को.
हाँ, ये एनाटॉमिकल पुली की तरह भी काम करता है. इट इंक्रीजेस द लिवर आल्सो, इट इंक्रीजेस द मूवमेंट आर्म आल्सो, एंड इट एक्ट्स एज अ पुली एज वेल. पुली क्या करता है? पुली का काम सिंपली होता है कि फोर्स का जो लाइन ऑफ फोर्स है उसको डिसिपेट करना. मतलब कि हमारा कहाँ गया, यहाँ पे हमारा क्वाड्रिसेप, जैसे पुली हमारा जो जो पहले के टाइम पे जो वेल्स होते थे ना, उसके ऊपर वो व्हील लगा हुआ, उसके उसके अराउंड हमारा जो रोप वूंड है ना, रैप है उसके अराउंड, है ना. एंड तो वो क्या कर रहा है सिंपली, मतलब हम यहाँ से अगर फोर्स लगाते हैं उस रोप पे, दूसरे साइड से हम देख सकते हैं कि बकेट को हम इजीली वी आर एबल टू लिफ्ट इट. क्यों? क्योंकि फोर्स अगर हम हर एक पॉइंट पे अगर हम चेक करें, हर एक पॉइंट पे अराउंड द व्हील, तो विल सी कि हर एक पॉइंट पे फोर्स वेक्टर का डायरेक्शन जो होगा डेट विल चेंज, है ना. एंड अगर फोर्स वेक्टर का डायरेक्शन चेंज होगा, तो बिकॉज ऑफ दैट सिंपली वी कैन से कि जो रिजल्टेंट फोर्स है, जितना पर्सन को फोर्स लगाना पड़ रहा है उस व्हील को, सॉरी उस बकेट को लिफ्ट करने के लिए, वो डिक्रीज हो जाएगा ना. तभी यही तो हमारा फंक्शन होता है एनाटमी, मतलब पुली का तो यही फंक्शन होता है ना, ताकि हमारा रिजल्टेंट फोर्स जो है वो डिक्रीज हो जाए. एंड सेम चीज़ हम देख सकते हैं, मतलब पुली वाला केस नहीं, लेकिन हमने जब स्टार्टिंग में क्लाविकल की बात करी थी, हमने हमने बात करी थी कि वाई द क्लाविकल इज एस शेप्ड. क्लाविकल का एस शेप था इसलिए बिकॉज एट ईच पॉइंट वी सॉ कि फोर्स वेक्टर की का जो डायरेक्शन था, that was decreasing at each point of the clavicle ना, and that was eventually decreasing the amount of resultant force जो कि हमारा clavicle के ऊपर था. हैं, तो वही वही चीज़ हम यहाँ पे भी देख सकते हैं कि resultant force डिक्रीज कर जाता है, and that also helps the quadricep to, with you can say with small amount of contraction of the quadricep we can easily produce knee joint extension ना. तो एक वो भी फैक्टर है जहाँ पे it is acting as an anatomical pulley. Along with that, if you talk about the movement arm, तो movement arm for the knee joint extension जो effort arm है, again that will also decrease if there is an absence of the patella in this case. ठीक है, I hope we are clear. ये I hope
Yes.
ये सबको ये पॉइंट समझ आया कि पटेला की एब्सेंस से क्या चीज़ होगी कि और क्यों होगा, ये सबको समझ आया. नी एक्सटेंशन टॉर्क है ना, सफिशिएंट नी एक्सटेंशन टॉर्क प्रोड्यूस नहीं होगा. ठीक है, ओके, चलो उसके बारे में फिर हम प्रॉपरली कल बात करते हैं पटेला के. एंड थोड़ा सा पटेला का बचा है, उसके बाद फिर हम फुट की बोन्स को हम कवर कर लेंगे. ज़्यादा कुछ नहीं है. इसके बाद थोड़े बहुत आर्चेज है, आर्चेज थोड़े बहुत है, बस वो हम कवर कर लेंगे. ये बस स्लाइड ज़्यादा लग रही है बिकॉज एक स्लाइड में एक ही इमेज आप देख लोगे. बस इसमें ये चीज़ इंपॉर्टेंट है कि व्हाट आर द स्ट्रक्चर्स विच पार्टिसिपेट टू मेक द मीडियल एंड द लॉन्गिट्यूडनल आर्च. उसके बाद में ऑफ कोर्स हमारी पेस प्लेनस केवस वगैरह के बारे में थोड़ा बहुत बात कर लेंगे. एंड this is important, what are the structures which are present on the lateral and the medial side, and कौन सी muscles होते हैं. we will see कि there are certain muscles also which provide the lateral and the medial curvature of the foot. तो अगर वो muscles अगर paralyzed state में चली जाती है, तो in that case we see the arch of the foot that decreases, है ना. एंड जहाँ पे पेस प्लेनस हमें देखने को मिलता है, we will talk about that. हम उसके बारे में बात करेंगे बाद में. ठीक है, कल बात करते हैं. एंड कल हम इसको कल यहाँ से स्टार्ट करते हैं फिर पैटेला से. ठीक है, ओके.
Okay, sir.
ठीक है, देन थैंक यू एवरीवन.
Thank you, sir.
ओके,
Thank you, sir. Thank you, sir.
ओके.